Here's some more interesting statistics. So one survey of physician executives showed that 95.7% reported regularly encountering disruptive physician behavior, and 70% said that it always involves the same physician. So it's typically the repeat offenders. Disrespect, refusal to complete the task, yelling, insults, physical abuse, again include throwing items, were the things they saw most. And one thought that 80% said the response said that disruptive physician behavior is underreported because victims fear of reprisal, or is only reported when the serious violations occur. So by this point, everybody knows about it, so they've got to report it. What's the prevalence of it? I won't go through all these statistics, but it's certainly out there, and it's now bubbled to the attention of the AMA and the Joint Commission. So some causes: career burnout, heavy workload, marriage troubles, and diagnosable psychiatric illnesses were kind of the general root causes.
The question is, do I have a God complex?
Dr. Kessler says yes.
Which makes me wonder if this lawyer has any idea as to the kind of grades one has to receive in college to be accepted at a top medical school. If you have the vaguest clue as to how talented someone has to be to lead a surgical team. I have an MD from Harvard. I am board certified in cardiothoracic medicine and trauma surgery. I have been awarded citations from 7 different medical boards in New England, and I am never, ever sick at sea. So I ask you, when someone goes into that chapel and they fall on their knees and they pray to God that their wife doesn't miscarry, or that their daughter doesn't bleed to death, or that their mother doesn't suffer acute neural trauma from post-operative shock, who do you think they're praying to? Now, you go ahead and read your Bible, Dennis, and you go to your church, and with any luck you might win the annual raffle. But if you're looking for God, he was in operating room number 2 on November 17th, and he doesn't like to be second-guessed. You ask me if I have a God complex? Let me tell you something. I am God.
Now, is that not an amazing clip? I mean, it completely obviously is way overboard, but I can kind of imagine some physicians who may have had a percentage or two of that behavior, and man, does he play that well. Although you can kind of tell, he has no idea what the hell he's saying. Acute neural trauma from post-operative shock. He probably didn't know how to pronounce the word neural trauma before that happened, and I'm not sure I know what it is. Anyway, 75% meet criteria for psychiatric disorder, 27% have chemical dependency, 52% have some type of mood, kind of dysthymic disorder, and 31% meet criteria for personality disorder, narcissistic or obsessive-compulsive personality. So when there's been some studies that have followed students who had challenges in medical school, and they've followed them through their career, and this is not something that easily goes away. Students who have problems in medical school with interpersonal conflicts with staff, other students, administration, or patients tend to typically, unless they were treated, these problems followed them throughout their career. So they undermine morale, certainly cause stress and frustration, impaired concentration, and certainly potentially negative patient outcomes and high staff turnover, whether it be the emergency department, the OR, on the floors. So some more consequences of disruptive behavior, and I know we're a little time constrained here, so I'll forward this on to Stephanie and she can send it out. When they abuse the students, although I always thought that was kind of a rite of passage when I was a student getting abused, or maybe it was just me, difficulty learning, anxiety, depression, and alcohol use, abusive treatment and role model pessimism, leads to learner dissatisfaction, burnout, and depression. And then again, kind of the pay it forward, and I think many of us are at the era where it was just generally you got a little bit abused by the people above you growing up, and growing up in healthcare anyway, and hopefully those days are long over. Interfere with staff ability to provide safe and effective treatment, undermine the confidence, and upset the effective teamwork dynamic. So the impact goes on and on through all aspects of an organization, and it affects, again, morale, turnover, patient safety issues, and certainly increased medical malpractice increase in medical malpractice. Now, what's the rationale for intervention? Well, pretty much everything that we just talked about. It certainly increases error, It can also lead to an inordinate amount of time spent appeasing or avoiding patients with complaints about staff error. So it always takes a lot longer to clean up the problems than it certainly does to cause them. It certainly causes a communication breakdown, and then safety and quality, which is things we depend on in our environment, can also break down as well. So the Joint Commission standard comes out of this LD 3.10 that leaders create and maintain a culture of safety, and that safety exists when all staff is focused on excellent performance. And the leaders need to create and then foster this patient safety, care-centric environment. So the Joint Commission was on to suggest developing disruptive standards, provide examples of what's acceptable and unacceptable behavior, and make available a code of conduct to providers to let them know the boundaries within which they need to perform, and then have each staff member, employee, and volunteer acknowledge and accept these policy and procedures. So in other words, everybody's singing off the same sheet of music. These behaviors are pretty clearly laid out. All right, this is okay. This is kind of gray. Now this crosses the line. So it's never surprised when you sit down with somebody and say, look, your behavior on this day fell below what we consider appropriate standards. Let's chat about this. And let's make sure it doesn't happen again, and here's how we're going to address it. So ensuring a culture of safety, regularly evaluate the safety and quality of the environment. It should be done at least once every 2 years, which seems a little lean to me. And again, acceptable code of conduct. So recommendations for actions, raise awareness is what we're doing. An internal assessment, which I suspect has been done already. Forming a multidisciplinary team to put groups of people together to start identifying and coming up with these boundaries within which to operate. Finding a clinical champion to foster the cause, and your whole medical staff is probably clinical champions for the cause here. And then secure leadership support and endorsement, which certainly seems to me from knowing people here and being here that you've already accomplished all this. Coming up with a code of conduct might suggest treat others with respect and dignity, conduct yourself in a professional manner, respond to complaints in a timely manner, no blaming or criticism, respect patients' rights, no racial or ethnic slurs, and behavior that may be considered sexual harassment. Some AMA publishes recommendations, which I won't read, and they're much like the JCHO's recommendations. And then post-incident, document it, create an incident report, letter notification to the parties, and then go through a fair hearing process. And this isn't done at the first time, but this is done when the behavior appears repeated or continual or not abating or absolving. And then finally, recommendations for corrective actions or otherwise after the fair hearing process. Now, I'm involved with a business that evaluates physicians who have had disruptive behavior or were alleged to have disruptive behavior, and frankly, sometimes it's the hospital trying to run somebody out of the hospital. It's rare. It's about 5% of the time. We've had a couple patients, a couple physicians who've come through, when at the end of the day, we do all these surveys of 360-degree surveys, and occasionally there's some agendas there that aren't always the ones on the surface. Again, very rare, but I've seen it happen. Finally, here are the take-home points. It's a safe environment. It's certainly necessary to promote patient and staff well-being within healthcare organizations, right? We're taking care of patients. We also need to take care of each other and ourselves. Certainly, a disruptive physician behavior violates a safe environment and can endanger patients. There's been plenty of studies that show nurses are less likely to call physicians who they feel are going to be threatening or abusive when they do call. They must be managed with a comprehensive approach that includes expectations, training, and discipline, and they have a much higher incidence of medical malpractice claims, much like that study in Blink. Now, not all physicians were disruptive, just their method of communication probably could have used some improvement. And with that, it takes 43 muscles to frown, 17 to smile, and it doesn't take anything to sit there with a dumb look on your face. So if you have any questions, otherwise, thanks for your attention.